Ladies and gentlemen, Chairman, my name is Malin Sternby Eilard, and I work at Sahlgrenska University Hospital in Gothenburg, Sweden. And I would like to thank the organizers for letting me present this study on transplantation, resection, and ablation for HCC in Sweden, based on the National Registry founded in 2008. And I have no disclosures. As you all know, there are three main treatment alternatives with curative intent in HCC. For patients with marginal liver function, transplantation offers good long-term results. For patients with large tumors, their resection is often feasible. And even for patients with a high load of comorbidity, there is an option in ablation. But for otherwise healthy patients with small tumors and preserved liver function, all these options are eligible. Many studies have tried to compare these treatments, but there's often a lack of randomization, which makes groups not comparable. An outcome is also dependent on the selection of the cohort, and for transplantation also the graft access and quality. So we wanted to compare survival after transplantation, resection, and ablation in Swedish HCC patients in relation to tumor stage, liver function, and comorbidity. And we also wanted to identify specific risk factors for each treatment group. We used prospectively collated data from a national registry called SWELIV for patients treated 2008 to 2016. And for this period, registry completeness was 95.6%. We did overall survival analysis for each treatment group and for selected groups with more equal tumor burden and liver function. And we analyzed risk factors for death with union multivariate Cox regression. We included 1,072 patients treated during this period, and we used an intention to treat approach for grouping, and this rendered 225 patients in the transplant group, 448 patients in the resection group, and 375 patients in the ablation group. There was also a small group with combined resection and ablation, which was excluded. And this slide is also supposed to demonstrate a complexity in treatment strategies for these patients, as many patients receive more than one kind of treatment. As, for example, in the transplantation group, 29 patients received ablation and one resection before transplantation, and 12 patients who had resection or ablation with a curative intent were later transplanted. And as expected, in the total cohort, 5-year survival was best for the transplanted patients with a 5-year survival of 76%. And for resected patients, 50%, and for ablated patients, 31%. However, these are not comparable groups. These are the descriptives with the total cohort in black and their respective treatment groups in white. And as you can see, the transplanted patients were younger, and a large proportion had planned TACE treatment as well as transplantation. The resected patients had larger tumors, and a majority had only one tumor. Also, almost half of the resected patients had no underlying liver disease, and there was a smaller proportion detected by surveillance, and more than half of them had a child score of 5. In the ablated group, comorbidity was a lot higher, with ASA score of 3 and 4, and also a larger proportion of alcohol etiology. So when we did multivariate Cox regression analysis on the respective treatment groups, we included factors regarding comorbidity, liver function, and tumor factors. And in the selected transplantation group, actually no comorbidity factor turned out significant, while alpha-fetoprotein was only significant in the transplantation group, whereas number was not in the resected group, probably due to the large majority of single tumors. However, it's worth noting that many of the risk factors in the resection group and ablation groups are actually protective in the transplantation groups, which make analysis a bit difficult. So we wanted to compare these treatment groups So we did selected groups with more equal liver function and tumor burden. So in the first group, we included 204 patients, child A, and with tumors of single tumors of no more than 5 centimeters. A larger group with also child A patients, but a tumor burden corresponding to the UCSF criteria, which are used for transplantation selection in Sweden. And then we also had a third group supposed to be used for compare the ablation patients compared to the other treatment groups. However, finally, since some palliative patients were included in the ablation group and also comorbidity data was a bit immature, we chose to exclude this from this presentation. So this is the first small selection group with a single HSC of no more than 5 centimeters. As you can see, there are still inequalities between the resected and transplanted patient. And the resected patients were older, had better liver function, less underlying liver disease, and also shorter waiting time. However, none of these factors were prognostically significant. Only alpha-fetoprotein was a prognostic risk factor in this group. And this is the survival curves. And as you can see there, until 3 years, curves are superimposed. And then there's an emerging but not significant difference in this small group, with age-adjusted 5-year survival of 77% for the transplantation group and 66% for the resection group. The little larger group with the tumor burden corresponding to the UCSF had a similar pattern with some differences, but none of them was prognostically significant, and only alpha-fetoprotein was prognostic in this group too. And we expected survival, a little bit more survival difference in this group, but it was the same pattern with superimposed survival curves till 3 years, and then an emerging survival benefit for the transplanted patient with an age-adjusted 5-year survival of 74% for transplantation and 66% for resection. And so we did multivariate models for this limited HCC group, and actually alpha-fetoprotein more than 100, and ASA of 3 and 4 was risk factors, while tumor size of more than 3 actually was associated with a decreased risk in this cohort. So our conclusions are that post-treatment 5-year survival for Swedish HCC patients was 76% for transplantation, 50% for resection, and 31% for ablation. In the more equal groups, survival differences after transplantation and resection were much smaller and did not reach significance. However, risk factors were different in each respective treatment group, and many risk factors in the resection group, resection and ablation groups were protective in the transplant group. Thank you.
Yes.
Thank you for your presentation. Have you some pathological data in the resection and transplantation groups? Because usually the resection group has a higher prevalence of a microscopic vascular invasion, a poorly differentiated grade with the same diameter. Have you this data in in your registry?
We have some data on that. We haven't analyzed this for this study. Perhaps we will, but this is mostly, I like to think that we like to choose our patients on preoperative factors.
Yes, but before transplantation, there is the problem of time that selected the patient. So
yes,
I think it's important to see to the pathological data. Thank you.
Did you look at the survival data beyond 5 years from operation? Because we know from previous studies, a lot from Dr. Vitale's works, that in patients with limited number and small HCCs, the survival up to 5 years, the survival benefit is not is either not big or it is negligible. But from other works, we know that when we look at 10 years or 15 years, these curves start to be really different. So did you analyze the survival data in the later period?
Actually, it's in the protocol, but since the registry was started in 2008, it's a bit premature to do the 10-year analysis.